Thank you for the invitation to speak today. My name is Lee James Sperling, and I'll be talking about a descriptive analysis of critical care admission data following emergency laparotomy. This work feeds into making a case for enhanced care admission for some patients after emergency laparotomy. So NELA and the ICNARC case mix program probably need little introduction. They both aim to improve emergency laparotomy and critical care outcomes, respectively, through, amongst other things, coherent data collection and outcome comparison. NELA also has a number of core process outcome measures, for example, that the majority of patients are admitted to critical care when the predicted risk of death exceeds 5%. To provide some background, to my knowledge, the nature of care given during critical care stays following emergency laparotomy has not been fully described. And this feeds into a hypothesis explored in this work. That is, that there exists a cohort who, while being high risk, may not require the full gamut of critical care resources. Instead, they may be appropriately cared for in an enhanced care unit. So, armed with linked patient-level data from NELA and the case mix program, we provided a descriptive analysis of the care received by these patients. It's worth a brief discussion of how the case mix program defines organ support, just to fully understand the remainder of this talk. For example, support of the cardiovascular system is either defined as advanced or basic. Advanced support includes things like multiple vasoactive infusions or continuous cardiac output monitoring. Basic level support can be continuous invasive pressure monitoring or being treated with a single vasoactive drug. Advanced respiratory support is predominantly invasive ventilation, and basic level support is non-invasive ventilation or a very high inspired oxygen concentration. Renal replacement therapy is recorded as is gastrointestinal support, mostly referring to non-oral nutrition. So starting with patients invasively ventilated, of the 26,000 or so patients admitted to critical care postoperatively, about 37% were ventilated on arrival in critical care. Roughly half of these were ventilated only for a short time, being extubated within the first 24 hours of their critical care stays. Of the 62% not ventilated, only about 5% required subsequent ventilation during those same critical care stays. There are many combinations of cardiovascular, respiratory, and renal support that can be offered to patients, and the most common combinations are shown in this table. In about a third of our cohort, the most common type of highest level of care that was given was only basic level cardiovascular support. So just recall that this is invasive pressure monitoring and or a single vasoactive or rhythm controlling drug. The next most common, found in about 22% of patients, was basic level cardiovascular support in invasively ventilated patients. Interestingly, about 62% of these patients were extubated within the first 24 hours of arrival. A similar size group had both basic cardiovascular and respiratory support. And another thing that is interesting to note is that overall renal replacement therapy is fairly uncommon, accounting for about 5% of patients overall. Also, amongst patients who survive their critical care admission period and are discharged from the unit alive, the length of stay in critical care varies quite considerably. For example, the longest stayers with a median stay of about 12 days for patients are those patients needing invasive ventilation combined with complex cardiovascular support and with renal replacement therapy. In the most common group, in other words, that receiving only basic level cardiovascular support, the median critical care stay was only about 2 days. It's interesting to observe as well that the longest critical care stays were frequently found in those patients needing renal replacement therapy. So, a priori, we defined a cohort that might be suitable for admission to enhanced care rather than requiring full critical care support. And we define this population as having really the most simple single organ support or monitoring, a short critical care stay of less than 48 hours, and who are discharged from the units alive. We identified about 6,900 such patients, which accounted for just over a quarter of our cohort. However, after looking at the results, this definition was tweaked slightly to include patients only having basic level cardiovascular support and excluding those having, for example, non-invasive ventilation. This only slightly reduced the cohort to about 6,700 patients. The reason for the definition change was related to 30-day mortality. Right at the beginning, I alluded to the key role that predicted risk plays in decision-making for post-operative admissions. For this subset, the NELA risk adjustment model predicted mortality was 7.6%. This would meet the critical care admission threshold suggested by NELA. So the majority of these patients would go to critical care after their surgery. However, the observed mortality was considerably lower at 3.6%. No such discrepancy, though, was seen between the observed and predicted mortalities for patients having only basic level respiratory support. Their 30-day mortality and predicted mortality hovered at around 6%. Now, even though there may well be better tools available for predicting mortality in a critical care cohort, this difference when using the NELA model is notable because of its role in decision making. There are a number of limitations to this work. It relies heavily on data linkage between NELA data and the ICNARC case mix program. However, this data linkage was lower than expected. Nonetheless, those patients with linked data do appear to be quite reflective of the cohort as a whole in terms of their demographic features, biochemical, physiological, and also pathological findings. Another clear challenge with this retrospective data is that the identified enhanced care cohort is clearly identified post hoc. It obviously doesn't help in terms of real-world decision-making, but it does demonstrate that there is potentially a population, and probably quite a sizable one, who could be cared for appropriately in an enhanced care environment. So just to close, the key messages from this work are that many patients only receive quite low-level intervention after emergency laparotomy and often only for short durations. Perhaps a slightly contentious comment to make is that deciding on post-operative care location based purely on predicted risk is quite a blunt tool. That said, it's still a useful one because it is difficult to identify suitable locations for patients' post-operative care, including enhanced care, especially before surgery. And perhaps to guide our decision making for the fairly new concept of enhanced care, each unit would need to have their own protocols informed by the best evidence, and perhaps some of this evidence might be through the development of predictive models and testing these and other tools in formal clinical trials. However, to me, this is quite good evidence that not all emergency laparotomy patients necessarily need full critical care postoperatively, provided that local enhanced care units are suitably resourced and have clear pathways for escalating treatment if there were a deterioration in the clinical condition. Thank you very much.